Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Tonight's topic is medical gaslighting, and I have a wonderful, wonderful guest, a good friend, Dr. Efrat Lamandre. She's a nurse practitioner, and that was what she actually wanted to talk about tonight, and I love that. I love asking my guests, what do you want to speak about? And our viewers and our great people who are watching us really are very interested in what's going on in the world. And maybe we'll start from the very beginning. I know you're a nurse practitioner, and try to explain to everyone what a nurse practitioner does. And because again, we're seeing so many people, we see physician's assistants, we see nurse practitioners in the office, and so many of my patients would rather see my nurse practitioner than me. I mean, nurses have a whole different demeanor in many ways. There's a whole different feeling with patients, the time, the thoughts, what they're doing. And I actually run a large multiple sclerosis center, and the nurse practitioners are pivotal and crucial to it. Asking about sexuality, asking about bowel and bladder symptoms in a slightly different way in order to get the answer, in order for the patient to feel comfortable, the person to feel comfortable, and to really get results. And that's so important. So tell us about what it's like to be a nurse practitioner, how you decided to be one, and what a nurse practitioner does.
So a nurse practitioner becomes a nurse first, and I think to your point, when you come from nursing first, you develop a bedside manner that is a little bit different, a different relationship to patients. And then you go back for more schooling to become a nurse practitioner. And there's different specialties. It could be family, pediatric, acute, gero, psych. And then after that, depending on what state you live in, will define your scope of practice. So in New York State, after you graduate, you complete 3,600 hours under a collaborating physician, and after that, you have full practice authority, which is how we have EG Healthcare here. EG Healthcare in Staten Island is one of the largest NP-owned practices in the country. We serve over 20,000 patients of all ages, with a special place in our hearts for the LGBT community, but all are welcome. And just like any other medical practice, we have the ability to do everything. To your point earlier, prescribe meds, order tests. For the patient experience is, in terms of what we're able to do, is identical to any other medical practice.
Super. And your patients love you, and I want to say thank you. I mean, when you refer patients over, and the amount of caring that they get at your group is really remarkable. And you really see that. Thanks.
We feel honored, honestly, to practice and take care of our own community. We love it.
That sounds great. So tell us about medical gaslighting. You wanted to talk about this. I had to ask my kids what we're talking about. Yes, I saw the movie. Yes, I heard all the analogies. I looked this up online. And when I read about it, I said, and we spoke a little bit beforehand, it's something that's happening to everyone.
It's happening to everyone. What did your kids say it was?
They gave me examples.
Oh, they did?
Yeah.
Do you remember any of them?
Yeah, they just said, if you go in and if someone walks in and they're a woman and complains of headaches, they were trying to be, or have numbness in their hands or feet, and your tests are normal, are you going to take their complaint seriously, or are you going to dismiss it? Are you going to say to them, there's really nothing wrong with you? You know, we do a lot of work with MS, and my major topic to internists, my medical residents, is if a young woman comes in with numbness in their hands and feet, you always have to worry about a disease like MS.
Sure.
Why? Because nobody wants to sit for whatever amount of time in your office, take time out of their day. They might have young children, they might have maybe working. Nobody wants to take 2 hours out of the day from the time they leave their house till they get home to come to your office. There's no great thrill, there's no enjoyment in that.
Yeah.
And the idea that if someone comes in with this, I tell my physicians in training, take their complaints very, very seriously. Nobody wants to do that. People with headaches, if they spend the time and really say, I need to see a doctor, and even if they're going to the nurse practitioner or family practice doctor, and they come to me afterwards because they're not getting enough or they need more or advanced treatments, that tells me how serious it is to them. So that's a whole situation in itself. So that's what I see with so many of our patients. And so many people are dismissed by having symptoms that are ascribed to they're young, or even they're old. You know, people who are older who have joint pain, it's arthritis. Sure. Everyone has arthritis.
Sure. So those are all really good examples, and I want to explain what gaslighting is and then explain why I think we see it so often. Because I think, like you and your colleagues, everyone is really caring. So I don't think gaslighting is malicious. So technically gaslighting, if we're talking about the psychological term, there is a malintent there to convince the person to question their reality. So it's a bit of a misnomer here. In medical gaslighting, to your kids' points, is when someone comes in and says, I don't feel well, and the provider runs all the tests, and all the tests come back normal. And once the tests come back normal, and once we are unable to find a disease, a pathology, there is a tendency to therefore say you're fine. And I don't think there's malice or malintent from any of my colleagues. I think we are taught in evidence-based medicine, the gold standard, it is that this toolbox is the only toolbox to use. And so we run the scans, we run the MRIs, and our patients come in and we are super caring and we're gonna run everything possible. But when those tests come up normal, we're almost by definition have to tell our patients, you are fine. And there is really no room in evidence-based medicine or conventional medicine to allow for other potential diagnosis or other toolboxes. So I'll give you an example. Headaches, right? We're gonna go for headaches. So the first thing we do with headaches, chronic headaches, right? We eventually are gonna scan, make sure there's no tumors, make sure there's no cancer. Okay, so we've eliminated that, great. That's great news, whew, so excited. Then based on the pattern of the headache, you might classify it. It's a migraine, it's a cluster, right? Based on the patterns and the symptoms. And then you might offer medications. There is a whole world of functional medicine, we discussed this last time, that will really go into the cause of why this headache is happening. And a very common cause of headache is something called mast cell activation syndrome. Another very common cause is people who are exposed to mold. These are two diagnoses that I see over and over again, and yet in evidence-based medicine, we don't discuss it. We don't even recognize it as diagnosis. So if someone's here with this issue of these headaches or dealing with this issue, when they come to our conventional medicine offices, we have to dismiss them because these concepts don't exist here. And so I really just want to say, like, the gaslighting is not malicious, but it's almost from indoctrination that this is the gold standard and anything that does not fit in these parameters doesn't exist or is less than. Let me pause there and kind of see how that's landing for you.
No, it's very interesting. And there are many people, what's interesting, we, as you said, the imaging studies, the CAT scan, the MRIs are normal in patients, in a vast majority of people who have headaches. Yeah. Then the question always comes to us is, are there any other tests or anything objective we could see? Of course, our examination is crucial, so we're able to examine the patient, the person, and see if there's anything abnormal, so that's great. There's blood work, there's response to therapies, some pharmacological, meaning medications, some non-pharmacological. There are relaxation techniques, that biofeedback. There's a number of things that we use, something called cognitive behavioral therapies, that really do help patients with headaches. And even people, even going further, people with attention deficit disorder, where the pictures will be normal, but they have the symptoms of attention deficit disorder. It's not always using medications. A lot of these techniques, however, do take a long time, going to a psychologist, spending time, and sometimes are prohibitive both in cost and time for most people to go through. So that's where medicines really do have a large part of what we do. It's interesting when you say it that way. I always look to say, how would you diagnose someone with mold exposure? How would you expose someone to a mast cell, which is a kind of cell in your blood, that basically causes this histamine release and all those things that it does? And without an objective, somewhat objective test, it's hard to figure out a treatment in my own mind. But if you think about it, MRIs, I've been in practice now for close to 30 years. MRIs were not that common when I first came out. You couldn't get an MRI on anyone. And when I was in medical school, I'll never forget that we got CAT scans on people, and CAT scans were available, but not everywhere. It wasn't in every single emergency room. I remember as a third-year medical student going from Coney Island Hospital to Kings County. I was in medical school in Brooklyn at Downstate, to take this one patient for a CAT scan. And when you had to have that much resources devoted to it, an ambulance, a healthcare provider going with the person, you had to be darn well sure why you're getting the test. Now we're getting these tests a lot more routinely, which is helping us in certain ways, but also difficult to say in different ways. So it's an interesting dilemma. What we always are looking for is some technique to make the diagnosis.
So they exist. And I'll speak to those in a moment, but I also want to say is that I believe you and many of our colleagues have a blind spot, because I am sure that the patients that you have diagnosed and who are responding, and you're like, look, I am doing this, that is great. But there is a subset of patients that are not coming back to you, that you no longer see, that you may just assume, well, they might be fine, and then come back to, right? So the ones that respond to medications, great. The ones that are okay with that diagnosis of migraine and you think it's hormonal, great. But there's a subset population that go to you and then to another neurologist and to the rheumatologist, and they're suffering and they're constantly being told they're fine, and you do not know they exist. Because after the first or second attempt with you, they're done. And they will come to someone like me, not in my primary care practice, but I don't do this anymore, but when I have my functional medicine, they will come to me and they'll say, I've been to 3 neurologists, I've been to 4 rheumatologists, these headaches are debilitating, giving it a name is not enough, I can't keep upping my meds. And then we're like, okay, and now we open up this other toolbox. And in this toolbox, we have objective testing. It's just not covered by insurance. It's just not validated yet by evidence-based medicine, but it will be over time. So we can do objective urine testing, simple urine tests, and it's relatively inexpensive to let us know if you have mold in your body. And there are really specific mold detoxification protocols that can be done. So not only can we test for it, validate it, we could treat, and then we could test for effective treatment. So there are, these tests exist. Food sensitivity tests exist. They're not recognized because they're not, right? They're not IgE, they're not recognized as food allergy is the only thing that is recognized in evidence-based medicine and covered by insurance. And so there are world and vetted laboratories that you have to pay cash for, that are not accepted here, haven't been validated yet, but they are replicatable, they are, again, measurable, and so we can absolutely diagnose these things and treat them.
We know about celiac disease, people who have wheat protein allergies. That's become very, not common, but at least well known in the community. Tell me a little bit of what other common food hypersensitivities or sensitivities that you see, and what symptoms do people have?
Well, let's talk about celiac for a second, right? So here in this world, I'm going to point here is going to be our conventional medicine, and here is everything else. And in conventional medicine, we only recognize celiac. But there is a world of non-celiac gluten sensitivity, NCGS, that you can't test for here. Here, if someone says to me, I have so much pain every time I eat gluten, and if they do a biopsy and that celiac test is negative, they're going to tell this patient, no, you don't have celiac, go ahead and eat the gluten. But that is not accurate. That means you don't have celiac, but the gluten sensitivity is on a spectrum, celiac being the most severe. But if you, every time you have gluten, you get tired, every time you eat gluten, you get bloated, every time you eat gluten, you have a headache, that is still a sensitivity to gluten that is not celiac. So there is a world of, there's a spectrum that we simply won't recognize, right? And that is, it's interesting. We recognize it in some diseases. Like we're willing to recognize the concept of pre-diabetes because we have a test for it that's paid for by insurance. But we won't recognize anything else on not a lot of things we recognize on the spectrum. That like, unless our markers, let's take a look at autoimmunity. There was a time where if someone came in and said, my joints hurt every morning, classic for rheumatoid arthritis, there was a time where if your RF factors weren't high, you would be told, well, you don't have RA, have a nice day. Now we recognize that there are seronegative patients, right? And so now the newer rheumatologists are saying, okay, we get it, your markers aren't there, but your symptoms match, your family history match, let's go ahead and start you on medication. So there's this beginning to understand that you can be symptomatic and you could be at the beginning of the spectrum, even though the evidence-based medicine toolbox doesn't kick in yet. And there's so much we can do here to validate and treat and improve people's lives if we don't limit ourselves to this.
Understood. And again, seronegativity is very common.
Yeah.
We have many diseases that do this. There's a disease called myasthenia gravis. We have seronegative patients. We have patients with something, with a certain kind of optic neuritis, neuromyelitis optica, which we can have seronegative patients. Almost every disease we do, because there's a false positive, false negative rate. So and there are people who just don't make enough of this antibody to become positive. So tell me, back to that first question. If somebody comes in with non-specific symptoms, and they maybe they don't recognize that it's when they eat wheat they get bloated each time. Maybe there's gluten, there's wheat proteins in everything, and there's grain proteins in all the grains. How do you sort it out? Because most people going to the doctor, and going to the doctor as a nurse practitioner, will come in with multiple issues. And it's not, very few people, unless they're coming for a well visit, for a job employment physical, will tell you, this hurts, that hurts, I'm feeling tired. And a lot of these can be tried to be explained by their lifestyle. You're not sleeping enough, people don't sleep enough, there's stresses. Everybody always asks me, does stress make things worse? And I said, well, go into my waiting room and just ask everyone in there who has no stress. Or the other way around, raise your hand if you have stress. And I think I did this once with my staff, and everybody raised their hand. So there are a lot of things that we have some control over to try to mitigate it or make it a little less, but these are things that are ubiquitous to the world. So how do you define, if somebody comes in with multiple complaints, where do you start?
From the beginning. So it's a great question. In conventional medicine, we're so focused on that HPI. We have limited time. And the HPI, we really are not interested in hearing from when they were born. Just tell me when it started. When did the headache start? That's really when we want to start hearing the HPI. Maybe a month beforehand. Mm-hmm. And it's simply not enough when we're, that HPI that we're learning how to do, it's simply not enough. When you sit with a patient,
and HPI means history of present illness.
History of present illness, yeah. So when you go into your provider's office and they're like, okay, when did the headache start? And they might say, oh, and when I was in first grade, like, no, I don't want to hear about that part. When did it start now? And there's this desire to get the story from here, from this almost as close as possible to present tense, in the HPI. Here, there's an understanding that things are cumulative from birth. What happened? How many times were you hospitalized? Were your tonsils removed? How many times were you on antibiotics? Was there a time where you were hospitalized for pneumonia? How's your stomach been throughout? Did you have irregular periods when you were 16? I know that you're now 47, but what happened? Because I could start seeing what happened to their microbiome when they were a kid, how their hormones were as teenagers. Did you have a concussion? Did you go to Mexico on your honeymoon and then you were never the same because you had some crazy GI disruption, and then you got a divorce, and then you went bankrupt, and then you got COVID? These are all, we are not the sum of the past 6 weeks. We are the sum not only of when we were born, but when we were in utero. And all the things that we were exposed to, and all the various physical and emotional traumas, they add up. And there is this load, and then this cup is full. And to your point about stress, yes, everyone in your waiting room has stress, but this person, whose cup is full, now has stress, that sends them over the edge. The other person in your waiting room is not as full. They didn't have pneumonia or a bankruptcy or a crazy GI issue or 3 surgeries or a car collision. So their stress doesn't tip them over the edge. So each person's cup is so individualized. And so when someone comes in and says, everything hurts, I have brain fog, my skin's a mess, I have psoriasis, I have eczema, I've been everywhere, I'm already on steroids, I'm on this, I'm on that. And I'm like, okay, what I'm seeing here, which is what we're busying ourselves in conventional medicine HPI, this is just the tip of the iceberg. This is already when things spilled over. And it is my job to go all the way here and figure out this whole situation and try to remove what I can, right? I can't remove what happened when they were younger. I can't remove the accident, but there are other things I can remove some of their food sensitivity. I can find out what's in their environment. I can encourage them to leave a stressful relationship because all of these parts play in. There is, you kind of develop, every one of us develops our own methodology. So yes, I'm going to clean up your diet. And if that solves everything, great, then that's what filled up your cup. And if I clean up your diet and you're still not well, I'm going to look for environment. I'm going to look for underlying infections, chronic Lyme. If that didn't help, I'm going to look at your central nervous system. Maybe you are really in fight or flight mode and you need some vagal nerve stimulation to help you get out of that, teach you about heart rate variability. So there are levels to it, right? There's no magic pill, but to really understand that patient who everyone has kind of dismissed, again, not with malice, just because they haven't found anything, is to really start from scratch.
So my son, who's in his mid-20s, basically is heavily into probiotics. Mm-hmm. And the microbiome has become one of the key new frontiers in medicine.
Correct.
And microbiome is the bacteria that you have in your gut, in your intestines, and basically your small intestines and large intestine. And the idea is that almost every immunological disorder, and that's being my specialty, being a neuroimmunologist, every immunological disorder appears to have a relationship to it. There's an idea that Alzheimer's disease, Parkinson's disease, some of the terrible neurodegenerative diseases, people with Parkinson's disease, interestingly enough, will oftentimes have constipation 20 years before they get any of the motor tremors, motor symptoms that you get. So we do see that. The gut has a lot to do with what's going on. Now, and actually, interestingly enough, some of the newer diet medications, are all affect chemicals that are in the gut, in your stomach, your GI tract, and your brain. So that's the overlap that we see. So it reduces it makes you feel full, both from your brain point of view, and it slows down things in your GI system to make you feel full. So tell us about microbiome and probiotics, and what's your feeling about it? And obviously you're doing a lot of work, as we talked about, more from my medical model. If someone's not feeling well, they come to you. Do you do things preventatively? Meaning if somebody comes in, 25-year-old comes in, they're just here for a work physical, and you see them and you say, you know what, maybe ask them, is you sleep great, you feel well about life, and some other things like that. Where does your gut come in, and what is your thought about probiotics, and should everyone be taking something?
Okay, I love that question. So microbiome, to your point, micro, small, bio means world. So there's a small world inside your belly. There's bacteria, protozoa, viruses, there's DNA segments all in here, and there's more of them than there is you, like cell for cell, right? So, and they don't just live here. We could not function without them. We cannot function without them. So it's not just, oh, my stomach hurts. It's the gut-brain axis, the gut-skin axis, the gut-mental health axis. So just about anything that's going awry in your body, perhaps with the exception of external infection or genetic mutations that you're born with, is going to be as a result of something happening in your gut. I cannot overemphasize how important it is that these cities that are in here are diversified, that we have a lot of the good residents, not too many bad residents, not too many pathogens, as many good bacteria.
I'm going to interrupt you. How do you know?
Yeah, okay, great question. First of all, if you're not well, you already know your gut's off. So if you're not well, your gut's off for sure. So the first thing you want to do is kind of balance your gut. And that's not, let me backtrack. If your gut's a mess, your gut's off. But if your gut's not a mess, but you have an issue, you have a skin issue, you have a joint issue, you have brain fog, your gut's off. Okay, so that's how you first know. If you really want testing, there are testing. There are labs that do amazing stool tests, again, not covered by insurance, where they give you the map of what's going on. How many pathogenic bacteria are in there, commensal bacteria, what's happening there.
How do you define these things? Pathogenic is bad,
yes.
Cause disease.
There's good bacteria, there's bad bacteria. It'll tell you if you're short on digestive enzymes, my apologies. So if you need to map it out, there are labs that do it. But honestly, once you kind of get the sense of your pattern of your patients, you kind of get a sense of whose gut is on point and who isn't on point. And if you're eating the standard American diet, your gut's not on point. It's not possible. It's not possible to feed yourself, I don't want to say brand names, but coffee with lots of stuff in it.
You could use it.
You're eating Dunkin' Donuts every day, and then Doritos every day, and Shake Shack every day. There is no shot that your microbiome is okay because you're not feeding it food. You're feeding it processed chemicals. So, in answer to your question, because the microbiome is so important for every single part of your health, it's critical that we fix it. Probiotics are great, and there's different kind of probiotics. But if you're eating probiotics without doing the day-to-day, meal-by-meal work, you're kind of spitting in the wind. It's better than nothing, but it is helpful. And then there's different strains of probiotics, and a lot of different diseases have been tied to certain missing bacteria in your belly, and so taking certain probiotics can help address that.
So tell me, when you mentioned processed food, so when I was reading an article, tell us the difference between processed and ultra-processed and food that you would rather people have.
So basically, if you could hypothetically make it in your house, it's not ultra-processed. So for example, I don't cook, so I don't actually make anything in my house, but I could make a chocolate chip cookie. Like I could conjure up what it would look like. I don't think I could ever make a Cheeto. Like I don't, right? There's no ingredients in my house or your house to make a Cheeto, right? I wouldn't even know how to begin, right? So that's ultra processed. You need some sort of processing plant to create this thing. I don't think either one of us can make Cheese Whiz, right?
Right.
So that's like a quick, easy way to kind of figure it out. Could you put these ingredients together? Maybe not well because you don't know how to cook well, but could you put these ingredients together and make this thing? Or do you need a science lab to put this thing? So that's the way to do it. And when you want to think, another way to think about it is, would this be on a farm, right? Beef would be on a farm, chicken would be on a farm, an egg would be on a farm, some vegetables would be on a farm, Cheetos would not be on a farm. So these are ways of so processed means, honestly, even cutting is processing. Anything that you do to food is a bit of processing. Ultra processed is where it's just a factory has to make it, and it's just chemicals that are put together, and they taste really good. They are processed to hit our bliss points, to make us want more, but they have no nutritional value. They're dense in calories. They make us put on weight, but they give us no nutrition whatsoever. So that's processed foods. And
what should we be eating?
Yeah, what should we be eating? So first of all, the general answer is always it depends, and it should always be personalized. So whenever possible, I try to customize it. But generally speaking, what I would say is diversify, right? So I'm about to say a word, I'm about to say plant-based, but I don't mean vegetarian. Plant-based means the majority of your plate should have some plants, colors. We talked about that last time. So as many colors as possible. Then a piece of protein of your choice. I prefer animal protein. My wife does not. So she will have some sort of vegetable protein or tofu or something like that. So a piece of some protein, definitely some fats. We need oils, we need avocado, and then very minimal carbs. And if that is how we construct our plate, we're in good shape.
Super. It's funny, when we spoke about you coming back on the show, I said we have like hours and hours of things to talk about. And I think you said we're just going to do one show, because I could do one show at a time. Our half hour is almost over.
Oh my goodness, that's amazing.
Is there anything you'd want, we have 30 seconds left, is there anything you'd want to tell the public who's out there?
Yes.
How to feel comfortable with their healthcare providers, how to be able to tell someone that you have a problem, and when to go to somebody who, like yourself, or someone who's more of a holistic approach than some of the conventional medicine?
Never skip, always go to your primary care first. Never skip that step. Make sure you max out everything in conventional medicine. And if they send you to a specialist, go to those specialists. Never skip that step and go to functional first. Any functional medicine provider will send you back. Once you do that and you still feel like your answers are not addressed, don't get angry, don't get frustrated. Understand that these providers are using one toolbox, and then find someone with a different toolbox. But listen to your gut.
Thank you so much. I want to say thank you for everybody for listening to us, and take some of these wonderful tidbits, and we'll try to all have a better and healthier life. Good night.